Dr. Tomáš Páleníček is part of the, is a researcher and a psychiatrist at the National Institute of Mental Health in Prague, Czech Republic. And he began his career in 2001 at the former Prague Psychiatric Center in a field of preclinical research. And he is focused on the neurobiology of psychedelics, such as, LSD, psilocybin, mescaline, MNDA, among others, and then on psychosis and also animal models. And today, Dr. Páleníček will talk about psilocybin in healthy volunteers and with respect to mood changes. Am I right?
Yes, yes. Thank you, Chris, for the introduction. And do you see my screen?
Yes, you're good to go. It's very clear.
Okay, perfect. So thank you very much for the introduction. And yes, my talk will be slightly different probably from the others because I will bring in the psychedelic topic and the effects of psilocybin that we have been studying in healthy volunteers. And we were looking on its long-term effects as well, a part of their acute effects, and whether we can predict the long-term effects using biomarkers from EEG that we were collecting during the psilocybin sessions. So first of all, there are some conflicts of interest. Now it works. So there are my conflicts of interest. Just very briefly, we have a psychedelic clinic that treats patients with ketamine, and we have founded a psychedelic research foundation here in Czech Republic. And I'm also giving consultancy for several other companies who are within the area, but they're outside of this work because this was a granted work from national funding sources. Okay, so what is psilocybin? Psilocybin is a psychedelic drug that is contained in so-called magic mushrooms or psilocybin mushrooms. This is an image of Psilocybe cervica variety bohemica, which is found in the country around autumn times. And psilocybin is in fact a prodrug of psilocin, which is the active compound. Psilocybin is dephosphorylated already in the stomach into psilocin, which then enters the organism and also crosses the blood-brain barrier and enters the brain. Not many people know that psilocybin and psilocin were also discovered by Albert Hofmann, the same person who discovered LSD. Psilocybin and also other psychedelics or serotonergic psychedelics are known to be agonists at 2A receptor, and it is believed that the 2A agonism is responsible for most of the components of psychedelic activity of these drugs. Psilocybin, however, has also the activity on some other receptors, especially 1A and 2C, but still the 2A seems to be the most relevant for its psychedelic potency. Psilocybin and other psychedelics are recently given lots of attention, especially due to the fact that they have been studies have been published showing that they have quite a unique profile in treating some psychiatric disorders, and one of the most promising domains seems to be in the treatment of depression. You are, as probably most of you are aware, ketamine is already approved as in the form of S-ketamine as a novel antidepressant, and it is also called so-called rapid onset or fast onset acting antidepressants. And psilocybin is a second candidate from these so-called fast-acting antidepressants, which looks like a very hot candidate. This is a study that was the first one published in patient population open label study. And actually what we see here is that psilocybin quickly improve the mood state of patients on the BDI score. And what is interesting, that the effect persisted after one dose, or in fact this study was 2 doses, for several months. Up to now, there were many more studies published regarding the efficacy of psilocybin in depression, and one of the most recent one, this is showing the prolonged effect of psilocybin on depression from the first study, and one of the most recent study that attained a lot of attention was this study that compared psilocybin compared to escitalopram in patients with depression, and they actually saw or discovered that psilocybin has a very comparable effect. The difference is that there was just one dose of psilocybin compared to continuous treatment with escitalopram, and it seemed pretty much the same in terms of the efficacy. So what does psychedelics do? They are also known under the, let's say, more broad name called hallucinogens, but as all these compounds, they induce three clusters of domains, three clusters of symptoms. One of them is somatic symptoms, which are typically mild sympathomimetic effects. Then there are these perceptual symptoms, which also gave them the name hallucinogens, and psychological effects, which can vary from states of very positive mood up to states with very anxious feelings and depersonalization and near-death experiences and so on. We can measure these effects. There is a scale that is frequently used to measure these acute effects, which is called altered states of consciousness scale. The scale has also evolved, but the traditional one has three domains only. Oceanic boundlessness, which refers to the positive-like experiences, dread of ego dissolution, that refers to the anxious-like experiences, visionary reconstruction, that refers to the perceptual changes, and the subscale, secondary scale, is referring to the overall magnitude effects. This scale is in general used throughout many of the studies with psychedelics these days, and I will show some results from our study with this scale as well. So I will show data that are coming from a clinical trial that we've still not completed yet fully, but almost completed. The study involved healthy volunteers in a crossover design, double-blind, who went twice for a psilocybin session, and the one part of the study focused on EEG data primarily. The second part focused primarily on MRI data. And this is the design of the EEG branch of the study, where you can see that we have collected EEG at different time points during the session. Psilocybin intoxication usually lasts about 3 to 6 hours. So we've collected data, EEG data before, and then at different time points after administration, and along with that several other parameters were also collected, which I will not show in here. What I would like to point your attention to is the last arrow on the bottom of the image, which refers to persisting effect scale, which in fact reflects how subjects felt 1 month after the drug experience. This is actually a Faraday cage, our EEG lab, where we perform the sessions. However, we designed it in order to make the environment as comfortable for people being under the influence of psychedelic drugs. And here are the results of the altered states of consciousness scale. So what we can see here, psilocybin induced quite strong oceanic boundlessness effects and visionary reconstruction, and there was much less on the anxiety subscale. When we look on the secondary scale, VWB, we can see that the effects were of lower intermediate potency. This is due to the dosage that we use, 0.26 milligram per kilogram, which refers to the lower end of the intermediate doses that are used these days. What we have also seen that the effects, the magnitude of effects, was dependent and correlated with the plasma levels of psilocin, the active metabolite of psilocybin. The persisting effect scale that I've mentioned a few seconds ago is a scale that was designed originally by Rolando Griffiths and his team and John Hopkins, and it's a scale that collects information about attitudes about life, self, and mood changes in a relationship and behavioral changes, and there are additional questions that are focusing on general meaning, spirituality, and satisfaction. The scale is not meant to measure the effects on mood in depressed patients, but was made to collect the information from healthy subjects. It looks like that. There are questions which had the opposite direction, asking always on the opposite polarity of the same topic. And actually, when we ask 28 days after being in our experiment subjects, how do they feel, whether something had changed, they actually reported only, in fact, almost only positive changes on the positive subscale in all the domains, and there was nothing on negligible negative effects. So we can technically omit that there were any negative side effects. That means that we've performed the experiments quite safely, and the subjects were quite satisfied and had long-term positive outcome on mood and all the other attitudes, which is definitely in line with the fact that in depressed patients it could have improved the mood state. What was interesting and also seems to be very like in the other studies is that the oceanic boundlessness effects on mood, the persisting effects on mood were driven by the oceanic boundlessness. That means the positive effects of the experience. So the more positive like experience, the more like positive mood change 1 month after the session with the drug. And the oceanic boundlessness also saw a positive correlation with the other subscales of the persisting effect scale. So the oceanic boundlessness seemed to be the most important factor that drives the effects in the long run. So this is the time course of change of psilocybin effects on EEG activity using Loretta. We know that most psychedelics, or in fact all psychedelics, typically induce changes within the alpha band, the amplitude, and decrease the current density in the alpha band. Here we see a little bit also some changes in the higher frequency bands that were significant, and we also see here the opposite, an increase of activity within the higher frequency bands. Starting from 21 till 40 hertz, but there's a problem as these drugs, especially during the onset of action, increase significantly muscle tension, so it's very difficult to distinguish that from muscle activity. So we do not count this as a brain activity, and we rather believe this is a muscle artifact. What is clear here that the effects were most pronounced during the 50 and 60 minutes, then they start to be less pronounced in the alpha band at 90 to 100 minutes, and we didn't see any significant effect later on that was remarkable within the current density analysis. What is known from other studies that psilocybin and other psychedelics, that from the network perspective, that they seem to increase the overall connectivity in between various structures in the brain on one hand. On the other hand, they decrease the within network connectivity, or they increase the variance of intra-network synchrony over time, and it could be also interpreted as they increase the and it has been shown that it increases the entropy in the brain during the acute intoxication. So actually, these are data also coming from our volunteer. You can see a signal coming from frontal cortex, where we were trying to locate the default mode network signal, and you can see the variability, the variance of the signal coming from this hub of default mode network is extremely high, has higher variability during psilocybin intoxication compared to placebo. What we have focused then, we've looked at the approximate entropy. As I said, the entropy has been shown previously to be increased by psilocybin. So we have decided, but it was shown from the MRI data, from the MEG data. So we have focused on approximate entropy using our EEG system. The first half of patients was recorded with only 19 channel 1020 EEG system, but we were still able to calculate approximate entropy. And actually, this is a map showing what were the effects of psilocybin during different time points before and after administration of the drug. What we can see that the approximate entropy increased at around 2 hours and remained high at 4 hours, but then it decreased, and especially in the frontal region at 6 hours, but remained persistent in the parieto-occipital region. So what we can see from this map that it looks like there are two different clusters that behave differently in terms of entropy, that the entropy might change in a different with a different dynamics. And indeed, when we isolated the frontal cluster, we have seen that the approximate entropy peaked during 2 hours, 2 hours after administration, so during the peak of effects, while the other cluster, which is central parieto-temporal occipital cluster, the approximate entropy increased at later stages of the intoxication and remains still very high at 6 hours. At 6 hours, the subjects were almost normal. So there's definitely something happening in the brain, and the state of the brain that was seen at the beginning was not comparable to the one that remained after the session, when people were already down back to normal. So something happened to psilocybin, something happened to the brain with psilocybin, and the brain shifts to a different brain activity state than it was at the beginning. When we looked on how the approximate entropy was linked to the acute experience, again, we found some correlation with the overall approximate entropy with oceanic boundlessness. So there was some mild correlation with this. But what is more important, we were interested whether the entropy somehow could be linked to the long-term effects on mood. And actually, when we were trying to find whether the peak of experience is important or which part of the experience or of the session, we actually found out that the entropy in the frontal cluster at the end of the session was the one that was predicting the long-term positive change in mood 28 days after the session, which has quite logic because frontal cortex and anterior cingulate, which is responsible for many of the symptoms of depression and evolved depression, are within the same region. So therefore, change in this region was the most important for predicting long-term effects on mood. And this didn't remain only in mood, but also in the other subscales of persisting effect scale. The other measure that we've recently used to analyze the data and to have a look on the EEG that were the analysis of microstates. Microstates are transient patterned quasi-stable states or patterns of an electroencephalogram. In fact, each EEG could be divided into a certain number of canonical microstates. There are methods how to calculate the optimal number of microstates, but most of the studies use and made a consensus that 4 microstates, A, B, C, and D, are those that are most typically representative for most of the EEG data. The microstates are characterized by several parameters. One of them is lifespan, that means the duration, how much time the microstate appears or persists, then is the frequency of occurrence. So there are these 2 parameters, and the overall frequency of how much they are switching is defined by the global field power peaks, GFP peaks. So what we have first done, because most of the microstates analysis are done within 2 to 20 hertz frequency band, and we know that psilocybin is decreasing the alpha activity, which is within this range, and shifting it towards the faster frequencies probably. So we did first of all 2 kinds of analysis. We analyzed within the 1 and 20 within the filter 2 to 20 hertz and 1 to 40 hertz, so to have different bandwidth where we've analyzed the data, and we looked whether the 4 microstates which are most frequently presented as being the standard are also seen here. And actually in our data set we have identified that there were most the ideal number of microstates was not 4 but was 3. So we adjusted our program to look at the 3 microstates mainly. We also have the data for 4, but as the 3 seem to be more optimal, we have I will show the data from the 3 different microstates. On this slide, we can see what happened within the 2 bandwidth windows. What happened with the GFP peaks? That means how fast how fastly the microstates were switching, and actually it's not so much seen in the 20 hertz bandwidth window, but much better seen in the 40 hertz window, that especially during the time 2 and 3, which are the time when the psilocybin has highest plasma levels and the experience is peaking, there was much more GFP peaks, which was statistically significant following psilocybin administration. So the signal was faster compared, the brain was switching the microstates faster than it was under normal circumstances. This is another view on the same model, which describes the lifespan. That means the persistence of each of the microstates and frequency of occurrence. Lifespan is on the left panel and frequency of occurrence on the right panel. The upper part puts all microstates together within the left graph and independent of time. Then on the right graph, it's all microstates together depending on time, and the bottom images show the individual 3 microstates, what happened to them. And what we can clearly see.
2 minutes to go.
Okay, I'm going to the end very quickly. So the microstates seem to that fits with the GFP peaks, which the signal was speeding up. The microstates were switching. They had shorter lifespan and higher frequency of occurrence. And when we look on the individual microstate, we see that the microstate B and C during the peak at time 3 was the one that had higher frequency of occurrence, and microstate A had higher frequency of occurrence at the time 2, also during the peak of experience. What is also interesting, what's the most interesting thing, we also looked on the analysis whether the microstate can predict somehow, the change in microstates could somehow predict the long-term effects on mood and well-being using the presenting effect scale. And actually, as I already mentioned, the negative effects of psilocybin in long-term are negligible almost. So I show only those which are in fact positive, related to the positive domain of the effects on persisting effect scale. And actually what we can see that the all changes refer to either increasing the frequency of occurrence or decreasing the lifespan were correlated with the positive effects. So in fact, the speeding up of the signal and speeding up switching the microstates was positively correlated in various areas with the long-term effects, and it wasn't related just to one specific microstate. So taken together, psilocybin-induced effects were intermediate potency in our study, and despite this fact, most of the subjects experience very lasting positive effects 1 month after dosing. The ocean boundlessness, so the positive valence of the experience, predicted the long-term effects on persisting effects scale. And psilocybin, from the EEG perspective, decreased the alpha current source density in occipitotemporal areas, increased intranetwork variance, increased approximate entropy, and in fact spatially biphasical effect, and increased the speed of switching the microstates. The prediction, the positive effects on persisting effect scale were in fact predicted by the final stage of the frontal cluster in the from the perspective of the approximate entropy, and by the speed of switching of microstates. So I would like to thank all collaborators, especially Nikola Jaikai, who did the microstate analysis, and Juliana Knocikova, who did the approximate entropy analysis, and also Martin Bornowski and all the other people who were volunteering or helping us with this study, including Martin Bornowski and many others. So that's all. I would like to thank you for your attention.
Thank you, Dr. Páleníček. There is a lot of questions today for you. For the sake of time, will maybe relay one or two. I think there is a lot to unpack in your presentation. It was very interesting, and this is such an actual topic about psychedelics, isn't that right? So I would like to thank you for your insightful presentation. There is a question from the audience, and it relates to what you said about microstates, I believe. And Rex asked if isn't this a function of internal language and speech? And then he said that he enjoyed your talk a lot.
Okay, thank you.
So I guess the question would be if this, what you presented, could be also related to internal speech or language.
Oh, yeah, I didn't get the. Sorry, I didn't get the. Yeah, can you repeat it, please? The question.
So Rex asks if isn't this all that you presented a function of language or internal speech?
Well, we didn't measure anything like that, like language or internal speech. We don't have any scales related to that. There are in newer versions of altered states of consciousness scale. There are 5D and 11D, 11-dimensional scale, which extracts more detailed features of the experience, but there is nothing linked to internal speech, in fact. So it would be very theoretical, hard to say. I think the most important balance of the experience that was driving the positive, long-lasting positive effects is related to emotional state rather than cognitive processing during the intoxication. Actually, recent studies show that the most important thing for a long-lasting effect is most likely linked to something which is called peak experience. That means a breakthrough experience that is driving a long-term positive change.
That's so interesting. Thank you for mentioning all these aspects, all these facets of these studies. I'm sure that we could speak for hours about all these topics. And there is a technical question which is more precise and related to the microstates part of your presentation. And this question is about how can you relate rTMS treatment for depression, for example, to your calculation of microstates or even entropy, and could that be used as a pacemaker to reestablish lower entropy state?
If rTMS could be established like that, well, actually, I'm not an expert on microstates. That's Nikola Jaikai who did the analysis. So, like for technicalities, it's better to write me, and I can link it to him because he performed the analysis regarding the rTMS. Well, theoretically, the RTMS, when we use RTMS for treating depression, that's usually stimulating the frontal cortex and with different frequencies, and the evidence, if I remember correctly, is for the slow frequency stimulating the dorsolateral prefrontal cortex, which is showing to be the most effective. I don't know if from these data, which have quite slow resolution, spatial resolution, we can focus on any specific structures. And the question remains whether with the angle coils which can stimulate up to the areas of the anterior cingulate, we can do better, we couldn't have better efficacy in treating depression, but this is probably not linked to this. I think the magic of psychedelics is that it's not about stimulating one particle structure, but it's about shifting a brain from one overall functional state to another one. That was particularly visible from the entropic state, that the entropy state that was at the beginning of the session was very different to the one that was at the end of the session, despite the subjects were at the same, let's say, level of consciousness or vigilance, because they were already, the intoxication was already over, but the brain still remained in a different state. And it is believed that the brain switches through the high entropic state or high connectivity, hyperconnectivity state with a lower integrity of networks to a different state, which then corresponds to the which is then manifested as change in mood in general. That's why all these substances like psilocybin, ketamine, and so on, they have so-called rapid acting effect. Actually, immediately after the session, people who were depressed before, if there is an effect, they are just without depression or with very high response. So
Okay, so
it's
interesting.
very different strategy than the standard antidepressant treatments.
I think this could be a long, one-day conversation about all these effects. And then my understanding this gives the opportunity of the system to reset itself, this long-term effect, as to giving it a nudge and then allow the internal chemistry and mechanics of the already existing human body to auto-reset to the best state possible due to these measurable microstates and entropy measures that you presented today. Thank you so much for this impressive presentation, Dr. Páleníček.